market. It's still an honor for me to be here. Well, what is lingual orthodontics? This is the only appliance which is really non-visible. I think there's no need for me to show this picture. And so this is fully invisible. This is relatively comfortable as an appliance, thanks to the material that we have, thanks to which we can cover the brackets and make the appliance more comfortable to the tongue and more comfortable to the patient. It does work. It's efficient in all types of malocclusions. This is just an overview of a number of cases that I treated over the course of the last 30 years. There are no limits. There are no contraindication. Of course, we need a minimum of cooperation by the patient, but we can also use TADs to help with some movements and a few extra appliances to provide en masse retraction. Now, everything changed when it comes to time and treatment time. Thanks to the new digital technology, the way it is used, lap side, but also church side, we do see that treatment times have been dramatically reduced. Today, lingual orthodontics is 100% digital. We start by impression taking, then we transfer the data on a lingual orthodontics software so that we can reduce the lab time to 2 weeks, and that's very important for you in your time management. In 2004 was the first time I treated a case 100% digital. So we segmented the teeth and we moved the teeth, and that was the first time that I could make this presentation. Back then, that was in 2004. And since then, since 2004, I've been treating all my patients digitally. So we start with digital setup. Then we position the brackets on the setup, all this, of course, in 3D, and then we transfer that in the mouth. And since then, of course, I've been exclusively working with straight wires. So you don't need to bend. You don't need to shape the wire, and they are provided to you directly with the brackets. Now, you have all possibilities to change the orientation of your teeth. You first need to start with the facial axis of a clinical crane, and this will help with that. And the software is going to help you move the teeth around the different axes of the teeth. Now, I use Onyx as a software, and we've also tweaked and changed that software in order to be able to perfectly position our brackets on our teeth. Now, thanks to that, we can check and also follow teeth movement over time, the reasons why there are malpositions, and we can, of course, adapt in the subsequent cases. Now, all teeth are in the same plane. You don't need to adapt to the curve of P, because if you would, then you would have a hard time placing your brackets on the horizontal plane. Now, those are some pictures of a setup that has been performed with Onyx. You see that the roots, so this is an estimation. This is not the real patient's teeth root position, but this is an estimation of what you have. Now, we also get information on the angle, on the tilt, on the torque, and to do so, we use a library of information that was set up by our American colleagues that were pioneers in lingual orthodontics. So we have a standard prescription, but then we're going to perform some specific overcorrections. And so what we have is not so much an aesthetic setup, but rather a strategic setup, which is going to depend on a number of factors. Obviously, I do not have enough time to give you all the fine details that would require a day-long class, but those are the type of parameters that we need to work with. Now, of course, depending on the type of malocclusion, the torque is not going to be the same and the bracket positioning is not going to be the same. So we start with the type of malocclusion, and then we're going to change the position of each tooth on an individual basis. Now here you do see that the lateral and the central are not going to be torqued in the same way. One is going to be intruded, one is going to be extruded. So we're going to change that depending, of course, on the proclination or retroclination of the teeth. Now we're going also to take into account the overjut. Now, of course, the size of the wire is paramount. We're going to change that depending on the slot. We're going to, and we need, of course, to know what is the size of the slot and how much leeway there is between the wire and the slot. Now, of course, depending on whether you want to have a horizontal retraction, and depending on the direction of the movement, you need to change your wire. Obviously, you have also different types of anchorage, be that dental anchorage or TAD anchoring. Also, alveolar housing is very fashionable currently, and this is also something that we're going to factor in when we send the prescription to the lab. Now, as I said, once the setup is finalized, you can add comments or you can ask the technician to make changes. So you can't make changes yourself, but the technician can make those changes based on your recommendations. And of course, you have all the torque, the difference. So the torque that is included in the setup and the torque that you would like to have. And this is going to help you know whether those values can be transferred in the clinic. So after setup is complete, we go for bracket selection. Most of the time we use self-ligating brackets, and we work with 3 to 4 companies providing lingual brackets. Of course, the innovation brackets from GC, GAC, are the most well-known on the market, they're manufactured on the market. You insert the arch vertically. Of course, I know that there are very strong proponents of the ribbon arch here, but those one are vertical insertion. Then you have also the Omco brackets, and then those brackets that I haven't tried, they are manufactured in China, and of course they do have the advantage of being extremely inexpensive. Now, when we talk about brackets, what also paramount is the size of the slot. So I have very precise gouge that are manufactured by a Swiss company, and I strictly always measure the slot, and I always go for a slot that is going to be 0.018 inch. And it's important to know the size of your slot because it's going to have an impact on your mechanics and also on your wire size selection. Now, once you know once you have all those information, then you're going to select your wire. And again, as I told you, I work strictly with straight wires, so I no longer bend. Now, in this graph, you do see that there's a difference in thickness in between the molars and the cuspids. And of course, you're going to select the height of your bracket in order to have your straight wire positioned in the most the optimal position. Of course, you need to be as close as possible to the enamel, and then you attach in the slot. So this is the difference between the size 1 and the size 5. Obviously, you do not get the same setup, and this, of course, is going to be customized to your patient. So you try to center your brackets, you try to place them in as much contact as possible with enamel. And when you use a straight wire, usually you have your brackets in enamel on the first molar as well. It's only on the lateral, on the posteriors, that you are not completely in contact with enamel. On the cuspids, you need to rotate from 5 to 10 degrees, which means that on the distal side of the tooth, we're not so much in contact with the enamel, but more in contact on the mesial side. But I shall pick up on that later. Now, once the attachments are properly positioned on the computer, now you need to transition that from the screen to the mouth. To do that, we want to do what is called digital transfer. Digital transfer, there are two sides to that. You have a 3D printed model on which you're going, so this is a resin part, and then you have another part to that device with a very precise contraption which inserts properly in the slot without too much leeway. And so you create a jig, and this jig is going to help with the transfer of what you have on the screen in the patient's mouth. Then we go for 3D printing, then we bond, then we place MemoSeal so that the different attachments are properly bonded and covered with MemoSeal. And again, what you get is exactly what was planned on the screen. So you bond one arch first, and then the second. You can start at the upper arch or the lower arch. Now, the most important factor in lingual orthodontics is the accurate positioning of your brackets. So I check the STL files. I do compare with the malocclusion model. And there's currently a study in collaboration with the University of USC in Los Angeles. And we're going to publish a paper whereby we demonstrate that we increase the accuracy and we reduce the number of mistakes when the entire process is digital end-to-end. This is the workflow. There's an entire loop here. So the first part is your part. This is your task and your job. You fill in the prescription and you decide on the treatment plan. Then the second plan is Lingual Liberty, so the software that I just discussed about the digital scanning. Then that's the attachment positioning, the manufacturing of the jigs. And then the part number 3 is done in partnership with your labs. They're going to print them and they're going then to prepare the transfer jigs. There are 2 labs in Paris which use Lingual Liberty. It wouldn't work without wires. So the wires are pre-bent, they're straight, as I said, and so we provide 6 wires for each case, 6 upper, 6 lower, respectively. And so what you get as a wire is exactly the wire that you had in your setup. Well, this, of course, is theory, because there are a number of things that may happen along the way, so that what you get clinically is not always necessarily the exact reflection of what you had during the setup. So you do have, as I said, a pre-shaped wire. Only in extraction cases, the wire is going to adapt to the curve of speed. Now, since 2005, I've always exclusively used straight wires because I think it makes my life easier. Chair side, I just have to open my drawer, fetch a straight wire. It's the same for all of my patients, so no bands. It's a lot more rigid. You know that in lingual orthodontics, when we have extraction cases, sometimes we're going to change the shape of the arch, and sometimes you have what we call the bowing effect, where the cusps and the premolars are sort of going out of the arch. So we do not want to have this bowing effect. With a wire which is more rigid, you're going to maintain the arch form. And so by not bending the wire, you have an easier time closing your spaces, and it's a lot easier chair side. Again, we have a wide array of wires. Again, no bend, so you have quite a selection you can pick from. They are pre-shaped, obviously, but you do not have to add any extra bends for most steps of your treatment. And of course, fast wire replacement, you do not need to order 2 special companies or labs to be able to change your wires. So again, saves time. So a few examples here. You do see that we were able to close the gaps. So this bowing effect, we have a lot less deformations or deformities as we used to have with bended wires, just again because the wire is a lot more rigid. And again, easy to change. You have quite an armamentarium of wires at your disposal directly in your drawer. So again, it's extremely accurate, it's faster, and the finishing, is most of the time the more time-consuming step. Well, this is mostly what they say, but you make this step quicker, easier, because again, you just reproduce what you had on your setup. And again, if you were accurate in the positioning of the brackets, then it's going to be fast, accurate, and very efficient. So in the past, we used to have those mushroom-shaped wires, but mushrooms are no longer in season, and so we no longer have mushrooms, we have straight wires. Most of the time, I'm asking my colleagues, well, what aren't you using straight wires? Most of the time, they answer one of those three things. They say, well, because I learned Lingual with bends, and it's hard. I have a hard time changing the way I work. Second type of answer I'm getting is because my Lingual guru told me it's no good to work with straight wires. And third type of answer, well, when you do that, then the bracket is not so much in contact on the cusps. So I also use Onyx for my setups. And on Onyx, that we discussed this morning, you can know precisely how far the brackets are from the enamel. On the side, you get that black box, and you do see that on the screen, that you have a bracket that is 1/10 of millimeter from the enamel surface. I conducted a study on my last 70 cases, and I realized that the cusp maximum is 0.75 millimeter from the enamel. Most of the time, most of them are comprised between 0.25, 0.20, 0.25, so there's not so much of a risk to have a problem of torque on the cusps. So I think it has a lot to do with preconceptions, and you need to change those. It is not true that space between and that gap with the enamel surface is really mundane. We're talking here about 0.22 millimeter. That's not much. That's not what is going to prevent you for having good control on the torque. But then, of course, you can still go with a mushroom wire. And in such a case, you're going to bend between the premolars and the cusps. Now, I would also like to discuss an orthodontics. So what does it mean, eco? It doesn't mean eco-friendly. It doesn't mean cost-saving. But it's just some type of orthodontic where we exert light forces, where we avoid round dripping, and where we reduce friction. This is a simple situation, the type of cases that presents in adults, at least in my clinic. This is when you have posterior crowding. Crowding. And what you do is create that space. You're going to start and align the upper arch with a 0.12 night-eye wire. So very fine wire, very light force. Then we increase, we transition to 14 square in order to control the torque. In 19% of the cases, the 0.16 is sufficient to do that. And then we go to the lower arch. And in case we have anterior crowding, two options. Either we're going to procline the incisor or we do IPR, or sometimes we do both. So it's pretty straightforward. And most of the time, we're going to use a light force, 0.12 night-eye. So we tilt towards the front, and then we use an elastic. And this, again, is done with light forces. And then once the anteriors are aligned, we will remove the turbos, and we get a good alignment. So we use that type of compressed wire technique. So it's a straight wire on which we're going to place an in-out, a sort of stop. So the wire is still activated, but in the anterior, it's activated on 2 to 3 millimeters. So we're going to engage in the brackets, and the teeth are going to be pushed forward, and you're going to reduce the crowding in the posterior segment. So you don't necessarily need stops. You need an in-out, and once you want to activate, you just push the wire forward, you glue. It's going to take a couple of minutes chairside. I know that you tend to see your patients every second to third month. I see them every month because it's a really short appointment during which I'm going to push those wires forwards if and when needed. Now, if you want to correct rotations, you do that tooth by tooth. The brackets lingually are very close. That's a fact. So you can't correct all the rotations with wire. And so you need to, you do not use the neighboring tooth to move the tooth. So you need to use an elastomere wire. So this is a simple case of crowding. We push the two central incisors, and we're going to place buttons on the lateral incisors. We're going to correct rotations. And once the rotations are corrected, we bond the brackets and we complete the alignment. And from start to finish, I didn't have to change the positioning of the wire. I didn't have to remove it and replace it. So everything is very simple. This is an example, which is a good demonstration. This is a typical case that we see in our clinic. This is an adult patient with a bridge with implants, and she consults for anterior crowding. We start at the upper arch to provide a good shape to the arch. We align the centrals and the laterals with a rather light wire. We bonded from 5 to 5. There was no need to go as far as the 7s. And then we place those compressed wires. We're going to procline the incisors. Sometimes we need to do IPR to avoid too much proclining of a teeth. Then we go to 012, 014, 016, 9 tie. Those are the same wires that I'm going to use at the mandible as well. And it's going to take only 4 months to resolve that crowding malocclusion. Now, today, when we want to show off during conferences, well, we present the setup and then we present the final situation, and it should superimpose perfectly well. This is exactly what I planned, and this is exactly what I got: perfect occlusion, perfectly straightened and aligned teeth. And this was a pretty straightforward and easy case. Upper arch, 3 wires, lower arch, 4 wires, pre-shaped. Take them directly from my drawer, and I change them when needed. And again, no bending for the finishing face. This is what we tend to do in extraction cases when you have a major crowding, class 2. We're not going to start on the laterals. Again, to avoid round tripping. And so we start on the centrals, on the cusps. We're going to distalize the canines, the cusps, with a stainless steel wire. And then once it's performed, we correct rotations, all that with straight wires, without bends. And it takes 5 months to have the incisors aligned, and then we do retraction. Another case, well, treatment planning was completely different. No extraction. We're just going to protrude the mandible. We need to change the inclination of the incisors, and we're going to intrude, or rather to tilt the laterals toward the inside. So we're going to change that, and we're going to again straighten the torque on the anteriors. We do that with night tie, straight wires. Before surgery, we place buttons. And this is the wire that I used in the upper arch. This is a perfectly straight wire, so I didn't need to bend. All this because I was very accurate in the placement of the brackets. The brackets were exactly positioned where they were positioned on the screen. Now, this is the final result, very similar to what was planned. You do see the change in the position of the central incisors on this X-ray, and you see the patient at the end of treatment. Now, what we want to aim for is a frictionless mechanics. Most of the time, well, in the past, we used to have a lot of sliding mechanics, but it does generate a lot of pressure and does impair the movement of teeth and makes the retraction phase very time-consuming. And I sometimes needed 8 to 10 months to retraction. It's a lot too long for adults, especially for wires that were not full-size wires. So you're losing torque during the retraction phase. Now, it's been a while now that I use a full-size rectangular wire from cusps to cusps. This is a wire which is manufactured by Wilcock, and this is what it looks like. It's very useful. You can also use it on the buccal side. And also for a while, I've used the BEG technique, where you would have a round wire inserted in a molar tube, and you would move your teeth that way. And this, of course, used to reduce friction very much. So I adapted that buccal version to the lingual take on this, so you get good vertical control. Those are examples. So you have 5 months between left and right, and so you were able to close the spaces in a matter of 5 months. In the past, it would take me maybe 8, 10 to 12 months to close extraction spaces. Yet another example, 5 months to retract. This is a Japanese patient with a vertical dimension problem. So during the retraction phase, we use levers, we use TADs. We have a bend here, usually from the molar, just to work on this vertical dimension in order to try and maintain the molars in the right position. And this is the final result. This is the before and after, with a retraction which only took 5 months. So that was the patient. So again, it's very easy to implement. It's not complicated. We prepare an 18 by 25 wire with that bend. In the posterior, we use a full-size wire from the second premolar to the from the premolar to the second molar, and we only engage the wire in the anteriors and on the tubes, the molar tube, and then with the bend, we have an intrusion force, which is going to be comprised between 100 and 200 grams. Another case, this is a patient who we are currently treating extractions of 4 premolars. And this was a combined treatment. So we have a self-ligating bracket with a molar tube as well. Again, we have this TAD plus a lever. And we exert that force around the center of resistance in order to have what we call a bodily retraction. And this is what we get. You do see the extremity of the wire going out of the tube. And again, it took 5 months. On average, it's 5 months when we have an uneventful treatment. And again, we're going to retract with more of a sliding mechanics. And sometimes it's so quick, it's so fast that sometimes you have an end-to-end occlusion because the upper arch tends to correct very quickly. But you do see, the treatment is not yet finished, but you do see an improvement on this patient's profile. And another example, this is an extreme case. That lady is end-to-end class 2 extraction of the pipes, and we want to have a retraction on the 5 anterior. So I use a segmented wire for the anteriors, full size, and then we finish with arms, and then I use a mini screw, a TAD, to have a retraction of the entire segment. It works very well. Again, treatment is ongoing, but in a matter of 2 months, I closed about half of the extraction spaces. Now we can also use other devices, what we call auxiliary devices, that are going to come as a complement to Lingual into Orthodontics. This patient already had 4 extractions, 4 premolars. She has a deciduous teeth, and the canine is in the location of one of the lateral. She's a class 3. We're going to use a maxillary skeletal expander. So this is something which was initially designed by Professor Moon in UCLA. So this is a new contraption, something that I use for a couple of months now, and it helps you change the maxilla by 6 to 8 millimeters without resorting to surgery. Of course, you use screws that are going to be inserted at the level of the first premolars, and it's really going to expand your maxilla, and it does change the shape. So it's very good in a matter of 3 weeks. This is what we get. Then, of course, we need to close that slightly as well. So we do that simultaneously. So first that distraction, the lingual attachments or brackets. Then we remove the distractor after 4 months. You remove the TADs, and you can solve that case without surgery. It's an ongoing case. Now, this is something that we treated in my lab in Bretonneau, and this was presented during one of our classes. The laterals and the premolars were crossbites. There was a crossbite at that level. We could discuss that later, if you don't mind. And of course, first you need to check the quantity of bone that is available. You need to find the most, the optimal placement for the TADs. We went for a setup, and this is the distractor on the setup. Again, the rings are just there to guide the movement of your distractor. They're not there to move the teeth. So we needed to gain 6 millimeters. And so in a matter of a few weeks, we gained those much needed 6 millimeter. So this is a case that I finished in my practice, because as I said, it was started in the university dental clinic, but I finished it in my private practice. And this is the final situation. And again, it does superimpose perfectly with the initial setup. This is our patient before and after. You see that her smile has changed tremendously. The upper arch is a lot wider, and there was no tipping in the premolars as we sometimes do when we do a lot of maxillary expansion, and we didn't have to go for surgery. If you're interested in that system, I do invite Professor Moon on the 23rd of November for a class. So I do invite you to take a picture of that website link, and this will point you to a website where you will be able to register for that class.
This is my clinical approach. Skeletal and soft tissues analysis is very important for adults. We also measure the tooth position. I want to find the torque of anterior teeth for malocclusion so that I can make the necessary corrections in the prescription. There is a specific prescription for each patient. The tooth movements are achieved with straight wires, and we use systems like MAC to complementary with the lingual orthodontics, and we've finished detailed cases with round wires for very small movements, 0.5 millimeter. In the finishing phases, we make a few aesthetic bends. I would like to show you one last case. This patient is 63 years old. This is what she looked like when she walked into my clinic. She had both a molar and canine class 2. She had periodontal issues, which were more or less treated by a general practitioner dentist. She's a doctor herself. She's a physician. There are extensive bone losses here. She is being monitored regularly by her dentist, and here you see an extensive anterior-posterior problem. Now here I would like to show you a picture to show you that the lower premolars are actually blocked by the upper premolars. Curve of Spee. And here we change the prescription for the patient. We make a setup. We place the attachments on the setup. We start with bite ramps, bite blocks, considering how bad her overbite is, but it doesn't really matter. I mean, it takes them about 1 week for the patients to adjust to the new chewing pattern. We did not bond all the teeth. The centrals were not bonded. We start using small buttons and elastics. 0.014 night eyes, a very, very light force wire. We start with the lower arch, and the trickiest part was to correct the position of the premolars on the left-hand side. 012, 014, 016 square, 018 square. I placed some temporary devices that I removed later. Now we remove the bite blocks. And this is what we want to achieve in the end. Well, you can't tell, but she still has a relatively back anterior-posterior shift. We prepared the patient for surgery because she actually agreed to be submitted to surgery. This is the day before surgery, and this is her after surgery. Not too bad. Not too much we still have to correct after surgery. Just give the teeth a chance to go in occlusion, and we finish with a 0.16 beta titanium square arch wire, not a wire that I use very often, but the 018 the square wire, and then the 016 beta titanium to finish the case. Those are the arch wires that I use at the end of treatment when I use straight arch wires in lingual orthodontics. Final result. The overimposed picture shows that you're doing a good job and you're a good orthodontist. We do this all the time, so before and after. All in all, 6 wires at the upper arch, 5 wires in the lower arch. Only one was not preformed, so I had to shape it myself. I didn't really bend it, I shaped it. The panoramic X-ray. And here we have the patient at the end of treatment. I promised her she would look 10 years younger. I'm not sure that I actually kept my promise, at least on the photograph. But she's very happy and she's smiling. Conclusion. I want to free lingual orthodontics. We need to free lingual orthodontics. We need to remove all the additional constraints that are being imposed on lingual orthodontics. We need to be free to choose the attachments, the arch wires, the mechanics, and the various accessories or devices that we want to use with lingual orthodontics. And also we should change the approach to lingual orthodontics. It should be user-friendly, very simple, very flexible. We shouldn't have to order additional accessories from companies. I mean, this is not easily done with adults. Once I receive the device, I don't want to have anything to do with the laboratory that provided the device. I want to do this in one go. And it means also that you have to use your experience and your skills. I'm sure you have the skill even for lingual orthodontics. I like photography, and I like this Japanese photographer. I love his pictures. And there was a show in Peru in February, and his pictures were plastered on a big wall. And I was actually quite surprised to find a picture of a Japanese set of lingual braces. It was a bent arch wire and double slot attachments, which I don't use. I mean, they're very good, but they're too difficult, too complex for me. Thank you very much for your attention. And one last thing. I was the first orthodontist to limit my practice to lingual orthodontics across the world. I don't want to be the last one, so 2 options. Either you start doing lingual orthodontics or you don't, and then you send the cases to me. Thank you.